Empty nose syndrome, ENS, arises when the nose becomes abnormally open after nasal surgery, often after reduction of the turbinates or conchotomy, while the sensory signaling that normally controls the feeling of safe, rhythmic breathing weakens or disappears. The combination of an excessively widened nasal cavity and lost nasal sensory input, reduced nasal turbulence, decreased breathing resistance, changes in temperature, humidification, and mucosal vibrations, means the brainstem no longer receives the airflow signals it needs to confirm that ventilation is stable and adequate. When these signals are missing, the brainstem interprets the situation as a potential ventilation threat. This activates a neurophysiological air hunger alarm that increases respiratory drive, raises sympathetic activity, and suppresses vagal tone from the very first breath. But ENS affects far more than nasal sensation. The fast, short, and resistance-free breathing that occurs when the nose is overly open causes the lungs' SAW receptors, slowly adapting stretch receptors that stabilize the breathing rhythm, to be underactivated, while RAR receptors, rapidly adapting irritant receptors, are overstimulated by colder, drier, and more unstable air. The result is an unstable breathing rhythm that drives hyperventilation and rapidly lowers CO2 levels. Falling CO2 then creates hypocapnia and respiratory alkalosis, which cause cerebral vasoconstriction, increased autonomic reactivity, palpitations, and an intensified sensation of air hunger. At the same time, the baroreflex is effectively knocked out, the body's most powerful reflex for calming the heart, because exhalation becomes too brief to build up the intrathoracic pressure required to activate it. When the baroreflex weakens, vagal tone falls, heart rate variability, HRV, decreases, the sinoatrial node, sinus node, becomes hypersensitive, and the entire autonomic nervous system switches into a hyper-reactive preparedness state. These mechanisms also affect higher brain centers, such as the insula, anterior cingulate cortex, ACC, amygdala, and prefrontal cortex, all of which interpret the sensory silence from the nose as a potential threat. This leads to increased interoceptive monitoring, amplified alarm responses, and difficulty shifting down into a parasympathetic state, especially during sleep. Together, this produces a cascade of mechanical, sensory, chemical, autonomic, and central nervous disturbances that make people with ENS extremely stressed, physiologically overloaded, and severely affected both awake and asleep. The review that follows describes step-by-step why this happens, and how each subsystem, the nose, the lungs, the brainstem, CO2 regulation, the baroreflex, the heart, and higher brain centers, is affected in ENS. 1. Loss of sensory information from the nose, how the brainstem is triggered into alarm. This is the most fundamental and at the same time most misunderstood mechanism behind empty nose syndrome. What disappears is not air, but the sensory inflow the brainstem depends on to regulate breathing, stress levels, and the body's basic homeostasis. I go through this step by step, anatomically, neurophysiologically, and sensorially. A. The turbinates are not just filters. They are a sensory organ. The nose is an active sensory module in the respiratory system. 3 things make the turbinates unique. 1. They create an aerodynamic flow that triggers receptors. When the nasal cavity has normal anatomy, inferior, middle, and superior turbinates plus septum, airflow is organized flow velocity, increases locally as air passes between structures, venturi effect. Turbulence and small vibrations are produced, cooling and changes in humidity hit the mucosa in a predictable way. This activates several sensory receptor groups. Receptor. Function TRPM8 registers cold and airflow, absolutely crucial for airflow sensation. Mechanoreceptors respond to pressure, flow, vibration. Thermoreceptors register temperature of incoming air. Moisture osmolarity receptors detect dryness of the air too. They use the V1 branch of the trigeminal nerve, EN, ophthalmicus. This branch of the trigeminal nerve is specialized for cold sensation flow, detection threat, defense signaling. It is the only sensory channel that tells the brain whether air is actually moving through the nose. 3. They provide continuous signaling to the brainstem. Unlike many sensory systems, which only respond to change, the nasal receptor system provides baseline activity on every breath. B. What happens when the turbinates are reduced or removed? When the turbinates are reduced or a conchotomy is performed, several objectively measurable physiological changes occur. 1. Airflow velocity decreases, what you corrected. You are entirely right. When the structures that create constriction in the Venturi effect are removed, the nasal cavity becomes wide open and the airflow becomes laminar and slower. Consequences: TRPM8 receptors, mechanical and thermal stimulation decreases markedly. Less turbulence, fewer vibrations, fewer signals to the trigeminal nerve. Lower flow velocity, less cooling of the mucosa, reduced airflow sensation. This is fully consistent with how the Venturi effect functions in all fluid and gas flow systems. 2. Pressure and resistance information disappears. The nose should normally provide the body with a sensation of resistance during inhalation. Pressure changes along the turbinates, a natural break that makes inhalation feel structured. When the resistance disappears, pressure differences become minimal. The brain receives no signals about how fast or deep one breathes. The brainstem control system faces a sensory vacuum. 3. Trigeminal input collapses. The brain does not interpret this as the air feels different, but as airflow is insufficient or dangerously low. This is a primitive protective reflex. The brainstem is very simple in its decisions. Is there cooling? Is there flow? Is there resistance? If the answer is no, an air hunger alarm is triggered. The increased respiratory drive, activation of the locus coeruleus, sympathetic center, vagal downregulation, hypervigilance, increased heart rate, inability to relax or sleep. Why the brainstem interprets this as acute lack of air. The brainstem, medulla oblongata, and pons uses sensory input from the nose in 3 important functions. Verify that inhalation is happening correctly. Is something happening in the nose when I breathe in? Adjust breathing rhythm and depth. This relies on trigeminal feedback. Regulate the autonomic system. Trigeminal input is linked to vagal and sympathetic systems via the nucleus tractus solitarius, NTS. When the input disappears, the NTS receives no signals. The brainstem believes flow is too weak. The respiratory center increases drive. The sympathetic system is engaged. This is why many ENS patients describe, the air doesn't feel real. I get no signal that I am breathing. My brain wakes up all the time to check breathing. I cannot relax. This is not psychology, it is pure neurophysiology. D. The emotional stress is a reflex, not anxiety. When trigeminal signals are absent, the following systems are reflexively activated. Structure, function. Locus coeruleus increases noradrenaline, modulates pain, causes hypervigilance. NTS, primary center for autonomic homeostasis, receives a lack of signals. Brainstem respiratory centers raise respiratory drive. Parasympathetic nuclei become underactivated due to sensory loss. The result: physiological panic, motor restlessness, chest tightness, increased pulse, difficulty falling asleep, awakenings with air hunger. This does not develop over weeks. It happens immediately when sensory input is missing. Summary of point 1: ENS leads to decreased airflow velocity, disappearance of turbulence in Venturi effect, marked reduction in TRPM8 activation, loss of flow and resistance information, collapse of trigeminal input, brainstem interpreting it as dangerously low ventilation. A neurological air hunger alarm is triggered, sympathetic activation, vagal system suppression, hyperarousal. This is a predictable, physiologically driven reaction, not psychological anxiety. Top 2. The lung receptors and why ENS makes the breathing rhythm unstable. The lungs contain several groups of mechanoreceptors, but 2 of them are central to stabilizing the breathing pattern. SAR, slowly adapting stretch receptors. RAR, rapidly adapting receptors, also called irritant receptors. Both sit in the bronchial tree and participate in continuous feedback between the lungs and the brainstem. ENS affects this system indirectly, but strongly, through altered breathing dynamics. A. CR, the body's stabilizing brake in breathing. What SAR does physiologically, SARs are located in the airway walls and are primarily activated by slow, steady, and relatively deep inhalation, progressive expansion of lung tissue, a certain duration of inspiratory inflow. Their functions include stabilizing the breathing rhythm, preventing excessive rapid breathing, activating vagal reflexes, contributing to lung protection against overinflation, Herring-Breuer inflation reflex. When SARS are properly activated, they send signals via the vagus nerve to the nucleus tractus solitarius, NTS, in the brainstem. This calms respiratory drive and creates a more stable breath-to-breath pattern. How ENS reduces SR activation? ENS implies markedly reduced nasal resistance. The effect becomes inhalation is usually faster, lower resistance, shorter inspiratory phase. Pressure changes in the lungs become more abrupt. Lung expansion occurs faster but with shorter duration. This means SARs do not have time to activate sufficiently because their physiology requires time, not just volume. A rapid inhalation activates them far less. Consequences: breathing becomes shorter and more fragmented. Rhythm in the respiratory center, pre-Butzinger complex, destabilizes. Vagal tone decreases. This is one of the fundamental mechanisms behind ENS-related hyperventilation and unstable minute ventilation. B. ARAR, the warning system that is triggered too easily in ENS. What ARAR does physiologically, your ARs are also in bronchial walls and respond to rapid pressure changes, mechanical flow, cold air, dry air, irritants and particles. Quick changes in lung volume, RARs are designed to increase respiratory rate if something disturbs the airways, trigger cough, activate the sympathetic system when the airways face a threat, signal discomfort, dyspnoea, and the need for faster ventilation. These receptors adapt quickly but are extremely sensitive to sudden phenomena. How ENS leads to RAR overactivation. Key physiological realities. In ENS, the nose's ability to warm, humidify, and break the air disappears. Air reaches the lungs colder, drier, and more turbulent. Inhalation is often faster because resistance is much lower. Lack of nasal function causes alveolar and bronchial surfaces to be more directly exposed to airflow variations. The combination of colder, drier air plus faster inflow plus greatly reduced nasal turbulence damping causes RARS to receive much stronger and more frequent stimulation. Consequences of increased RAR activation: higher respiratory rate, more sympathetic activation, increased sensation of dyspnoea, reinforcement of hyperventilation, stress signals to the brainstem. This becomes a vicious circle because RAR activation makes breathing even faster, which lowers CO2, which in turn increases sensitivity in both RARs and the carotid body chemoreceptors. See why the SAR-RAR relationship is destroyed in ENS. In a healthy system, balance prevails. SAR provides calm, stability, and rhythm. RAR warns when necessary. ENS causes SAR to signal too little, RAR to signal too much. The respiratory center interprets this as too little lung expansion per breath, too rapid change of pressure, flow, stimulation of airway warning receptors, result, increased respiratory drive, difficulty maintaining a slow breath, sensation of unstable breathing, increased sympathetic activity, reduced vagal tone, increased tendency to hypocapnia, higher heart rate and worse heart rate variability, HRV. This is not psychological stress. It is a real physiological sensory chaos throughout the airway brainstem system. So now point 3, deepened physiological explanation. Baroreflex, exhalation against resistance, and why ENS knocks out this mechanism. The baroreflex is the body's most powerful reflex for calming heart rhythm and reducing stress. It works by baroreceptors in two large vessels, sensing how much the vessel wall is stretched. Carotid sinus, the carotid artery before its bifurcation. Aortic arch, the curve of the aorta before it descends into the abdomen. These receptors sense real-time blood pressure changes. But for the baroreflex to activate properly, a certain breathing pattern is needed. Long, slow exhalation against resistance. This is precisely what collapses in ENS. Below follows the physiological mechanism step by step. 1. Intrathoracic pressure. The key to everything. The chest is not an empty space. When you exhale, pressure around the heart, lungs and large vessels changes. When you exhale quickly without resistance, as in ENS, the pressure increase is very brief. It does not reach the level required to stretch the aortic arch. The carotid sinus is not adequately stretched. The baroreflex is weak. B. Exhale slowly against resistance, normal nasal resistance, slight pursed lip breathing, etc. Intrathoracic pressure rises slowly and steadily. The vessels in the chest are exposed to a gradual external pressure increase. The aortic arch is gently compressed. The carotid sinus receives a steady pressure signal. Baroreceptors are strongly activated. This pressure rise is not a violent compression. It is a mild, slow increase that vessels are made to register. 2. Why the vessels are affected by what you do in the lungs. It sounds like two separate systems, but the lungs, the heart, and the large vessels lie inside the same pressure chamber. The thoracic cavity. Inside the chest, there is a common pressure, intrathoracic pressure. That pressure changes with each breath. When you exhale against resistance, the lungs expel air more slowly. The diaphragm moves up slowly. The chest cavity lowers more gradually. Intrathoracic pressure increases in a soft and steady way. This pressure directly affects the aortic arch, lies in front of the spine, behind the sternum. The carotid artery, indirectly via altered blood flow from the chest. The veins draining into the right atrium. The atria and ventricles of the heart. It is therefore the surrounding pressure in the chest that lightly presses on vessel walls, not air in the lungs per se. 3. How baroreceptors are activated by this. When pressure rises slowly in the thorax, the aortic arch is exposed to increasing external pressure. The vessel wall stretches steadily. Baroreceptors receive a constant signal. The signal travels via glossopharyngeal, N. glossopharyngeus, and vagus, N. vagus, nerves to the NTS in the brainstem. NTS activates the nucleus ambiguus. The vagus increases tone to the sinoatrial node. The heart is slowed and rhythm stabilized. This is exactly what happens during deep nasal breathing through normal turbinates, pursed lip breathing, CPAP, slow breathing at approximately 6 per minute, certain meditation techniques. It is therefore a physiological braking system built on chest mechanics. 4. Why ENS knocks out this mechanism completely. ENS implies the turbinates are reduced or removed. Nasal flow resistance disappears. Consequences: exhalation is always too fast, 1 to 2 seconds instead of 4 to 6. Intrathoracic pressure spikes briefly and disappears. Vessels never have time to stretch. Baroreceptors register almost nothing. No calming vagal activation. Vagal tone falls. The heart loses its brake. The sinoatrial node becomes overactive and stress-sensitive. Sympathetic activity takes over. HRV decreases. Bodily stress increases. The body loses its most important natural calming mechanism. This is why many with ENS describe a kind of continuous internal stress motor, even while they try to rest or sleep. 5. A simple analogy physiologically correct. Imagine the aortic arch functions like a spring that should sense pressure. If you press slowly and gently, the spring reacts strongly. If you press quickly and release immediately, the spring barely reacts. ENS makes all exhalations of the quick type. The baroreflex does not have time to activate. Point 4. Deeper physiological explanation. The sinoatrial node and why ENS disrupts the entire autonomic regulation. The sinoatrial node, sinus node, is the heart's primary pacemaker. It consists of a network of specialized myocytes in the right atrium that can spontaneously generate electrical impulses. Those impulses spread through the atria, pass to the AV node, and then set the frequency for the entire heart. The sinus node's activity is regulated by two main nervous systems. Sympathetic nervous system increases heart rate and excitability. Vagus nerve, parasympathetic, slows and stabilizes rhythm. It is the balance between these that keeps heart rate stable at rest and allows the body to calm down, lower blood pressure, and enter sleep. How ENS affects the sinoatrial node. ENS produces several changes that strongly weaken vagal inhibition of the heart. To understand the consequence, it is important to see how the sinus node reacts to altered autonomic input. 1. Loss of vagal brake. The sinus node becomes hypersensitive. Under normal conditions, the vagus sends a continuous stream of inhibitory signals to the sinus node. This basal inhibition keeps resting heart rate low, dampens cardiac excitability, allows high heart rate variability, HRV, permits a calm transition between phases of breathing. In ENS, many of the reflexes that normally activate the vagus, e.g. the baroreflex via exhalation against nasal resistance, are weakened. When that brake is lost, the sinus node adopts a different physiological profile. Rhythm becomes looser and more unstable. Resting heart rate rises. Small stress signals have large consequences. HRV falls markedly. This is a central mechanism behind the typical hyperarousal many with ENS experience. 2. Increased sympathetic activation. Sinus node excitability rises further when trigeminal and receptor input from the nose collapses and air hunger reaction arises in the brainstem. This increases sympathetic activity via locus coeruleus, hypothalamus, brainstem autonomic nuclei. Increased sympathetic tone makes the sinus node faster, more sensitive to catecholamines, more variable in impulse frequency, worse at slowing during exhalation. Together with reduced vagal tone, an autonomic imbalance arises that makes the heart overreactive and difficult to stabilize. 3. Carbon dioxide deficiency, hypocapnia, direct impact on rhythm stability. ENS often causes too rapid a breathing pattern. This lowers CO2. When CO2 falls, cerebral blood supply decreases, pH changes, central chemoreceptors signal threat. Sympathetic activation increases further. This pushes the sinus node toward a readiness rhythm even at rest. Low CO2 also destabilizes cardiac conduction by affecting ion channels and membrane potentials in sinus node cells. 4. The trigeminal vagus coupling is lost when the nasal cavity no longer provides normal sensory input. During normal breathing, there is a tightly integrated reflex coupling between trigeminal airflow and cold receptors, nucleus tractus solitarius, NTS, in the brainstem, vagal nuclei, the sinus node. When the turbinates are absent or markedly reduced, airflow signals disappear, temperature changes disappear, mucosal vibrations disappear, mechanical feedback from the nasal cycle disappears. This sensory silence is interpreted by the brainstem as a ventilation threat. The response is a strong sympathetic surge, which again affects the sinus node. 5. Why this leads to a chronic stress motor in the body. When the sinus node is no longer inhibited by the vagus and simultaneously receives continuous stress signals from the brainstem, the following occurs. The heart remains at too high a resting rate. Pulse varies rapidly even with small stimuli. HRV decreases, sign of low parasympathetic tone. Sleep fragments. Nocturnal tachycardia occurs easily. Small breathing variations create disproportionate rhythm changes. The whole autonomic system moves toward a chronic alarm state. This is why many with ENS describe a constant internal stress feeling, even though it is not psychologically caused. It is a physiologically driven dysregulation where the sinus node exists in a near-permanent readiness mode. Point 5. CO2 disturbance. The chemoreflex and why ENS can create both acute and chronic hypocapnia. Deep in physiological review, carbon dioxide, CO2, is a central regulator of respiratory drive, cerebral blood flow, pH balance, and the balance between sympathetic and parasympathetic tone. When someone with ENS begins to ventilate too quickly, often due to poor perception of airflow and absent trigeminal input from the nasal cavity, CO2 levels drop. This creates hypocapnia in a physiological stress reaction that can be both intense and difficult to control. This section explains why this happens and how both acute and chronic mechanisms can contribute. 1. CO2 as the primary regulator of breathing. Breathing is primarily controlled by central chemoreceptors in the medulla oblongata, peripheral chemoreceptors in the carotid body, glomus caroticum. These receptors detect CO2 level, pH, carbonic acid bicarbonate balance, oxygen level. Among these variables, CO2 is the most potent signal. A very small change in CO2 can produce a large change in breathing pattern. When CO2 falls, respiratory drive paradoxically increases. The rhythm becomes unstable. The body enters a compensatory state that feels like stress or air hunger. This is a reflex, not psychology. 2. Why ENS leads to a primary CO2 drop. ENS implies the nose has lost its normal resistance and sensory signaling. This leads to faster, shallower breaths, increased minute ventilation, poorer ability to dose inhalation timing. What drives this primarily is sensory mismatch. The nose no longer conveys normal information about airflow, temperature, cooling, and resistance. The brainstem interprets this as insufficient ventilation. Respiratory drive increases compensatorily. Ventilation becomes too fast and CO2 is blown off. Result, acute hypocapnia. 3. What happens in the body when CO2 falls? 3.1. Respiratory alkalosis, pH rises. When CO2 is removed too quickly, the pH rises, producing increased neuronal excitability, pins and needles, numbness, muscle tension, chest tightness, and discomfort. 3.2. Cerebral vasoconstriction. CO2 is the brain's strongest vasodilator. When CO2 falls, blood vessels constrict, cerebral blood flow decreases, dizziness, derealization, tunnel vision, and cognitive fog can occur. 3.3. Cardiac and chest symptoms. Hypocapnia affects chest muscles, diaphragm, and cardiac autonomic regulation. It can be experienced as discomfort, palpitations, difficulty achieving a calm exhalation. 4. Secondary mechanism. Long-term adaptation of chemoreceptors. With chronic hypocapnia, a known physiological adaptation occurs. Chemoreceptors in the carotid body and brainstem adjust their sensitivity. It works like this. Stage 1. Prolonged low CO2 levels cause the body to regard the low level as the new normal. Stage 2. Chemoreceptors downregulate their threshold. They become more sensitive to small increases in CO2. This means even a small CO2 rise is perceived as too high. Compensatory respiratory drive is triggered more quickly. Breathing becomes even faster and more unstable. This is an established physiological phenomenon seen in chronic hyperventilation and some chronic respiratory conditions. It creates a secondary reinforcement of hypocapnia. The body becomes locked in a vicious circle where the receptors themselves contribute to keeping CO2 abnormally low. For people with ENS, this may help explain why hyperventilation patterns often become chronic. 5. The chemoreflex role. The chemical alarm reaction. Peripheral chemoreceptors in the carotid body react to 3 things: CO2, pH, oxygen. When CO2 is low and pH high, the cells in the carotid body become more excitable, more reactive to small gas changes, quicker to send imbalance signals to the brainstem. This leads to intensified respiratory drive, sympathetic activation, rapid heart rate, a physiological panic reaction that cannot be thought away. 6. Effects on the autonomic nervous system. 6.1. Increased sympathetic activity, low CO2 drives, higher heart rate, difficulty relaxing, restlessness and internal stress. Unstable sleep. 6.2. Inhibition of the vagus nerve, respiratory alkalosis reduces vagal tone. The result? Poorer heart rhythm control, less stress damping, reduced HRV, higher basal sympathetic level. The vagus thus loses its braking function. 6.3. Activation of the HPA axis, prolonged hypocapnia, and sympathetic dominance can raise levels of noradrenaline, adrenaline, cortisol. This reinforces hyperarousal over time. 7. Why hypocapnia is felt as physiological panic. 3 mechanisms operate simultaneously. Sensory mismatch from the nose. The brainstem receives too little trigeminal information and interprets it as insufficient ventilation. Cerebral vasoconstriction. Reduced brain perfusion produces a threat sensation, dizziness, unease. Chemoreceptor hypersensitivity. Low CO2 renders receptors hyperresponsive, and they trigger an even stronger respiratory drive. These 3 combine to create an experience that is entirely physiological and not psychologically caused. Summary of point 5. ENS can create both a primary and secondary disturbance of CO2 balance. Primary mechanism: lack of nasal sensory input, overventilation, acute CO2 drop. Secondary mechanism: prolonged hypocapnia, chemoreceptor sensitivity shifts. The body becomes locked into a hyperventilation pattern. This leads to respiratory alkalosis, cerebral vasoconstriction, vagal inhibition, sympathetic dominance, a physiological panic reaction. It is all about physiology, gas balance, autonomic reflexes, and neurochemistry. Point 6. Deepened physiological explanation. Higher brain centers, interoception, and why ENS creates a central threat state. Empty nose syndrome causes not only peripheral disturbances in the nose, airflow, and respiratory physiology. A large part of the severe stress reaction also arises in higher brain centers that integrate bodily signals and determine whether something is perceived as safe or threatening. When these systems are exposed to incorrect, incomplete, or contradictory sensory information from the airways, the brain ends up in a chronic alarm state. This is a neurophysiological process, not a psychological interpretation. 1. Insula, Center for Interoception and Body Feeling. The insula is the area that constructs the experience of airflow, the body's internal state, the balance between exertion and recovery. When nasal sensory input collapses due to reduced or removed turbinates, several changes occur. Airflow feels weak or absent. Pressure and temperature information disappear. Cooling of the mucosa, TRPM8 signals, is drastically reduced. Resistance sensation is lost. The insula then receives a sensory picture that does not match chest and lung mechanics. This conflict leads to a sense that breathing is not registered, an undefined internal air hunger, a feeling of incomplete inhalation, even with normal ventilation, increased vigilance on every breath. The brain interprets this as a potential threat signal. 2. ACC detects mismatch and triggers autonomic activation. The anterior cingulate cortex, ACC, is a central node for conflict and mismatch detection, regulation of autonomic activity, redirecting attention toward bodily signals. ENS creates 3 types of mismatch to which the ACC responds strongly. Sensory mismatch. The inside of the nose feels silent, despite large airflow. Mechanical mismatch. The chest expands, but nasal receptors signal no air passage. Autonomic mismatch. fast breathing and tachycardia without an external threat. The ACC treats these conflicts as an internal error that must be corrected. It increases sympathetic drive, heart rate, respiratory drive, attention to breathing. This makes breathing more effortful and more conscious. 3. Amygdala. Amplification of the autonomic alarm. The amygdala reacts strongly to signals suggesting oxygen deficiency or ventilation disturbance. It is activated by air hunger, unexplained bodily sensations, unstable breathing patterns, tachycardia, sensory silence from the nose. The amygdala cannot understand that the symptoms are surgically caused. It interprets them as signs of a threat to survival. It therefore forwards signals that increase adrenergic activity, arousal, muscle tension, stress response. This contributes to the characteristic constant internal alarm many with ENS describe. 4. Prefrontal cortex. Impaired regulation of bodily threat responses. The prefrontal cortex functions as the brain's brake. Under normal conditions, it dampens amygdala reactivity, unwanted autonomic activation, excessive interoceptive attention. In ENS, this system is heavily burdened because nasal sensory input is insufficient or incorrect. The chemoreflex is overactive during hypocapnia. Sleep quality is reduced. Vagal tone is low. These factors impair the prefrontal cortex ability to keep the amygdala in check. The result? An easily triggered stress system, high baseline anxiety in the body, difficulty returning to parasympathetic rest, reduced tolerance for stress and stimuli. 5. Interoceptive hypersensitivity. Why everything is felt more intensely. When nasal sensory input weakens, the brain relies more on chest proprioception, chemoreceptor signals, heart rate, diaphragm movement. This increases interoceptive amplification in the insula and ACC. It means greater attention to each breath, increased awareness of heart rhythm, amplified perception of chest tightness, air hunger, or pulse. A similar mechanism is seen in other conditions where sensory input decreases, e.g. tinnitus after hearing loss. 6. Why this creates a central threat state. Several parallel processes make the brain interpret the situation as an ongoing threat. Airflow signals are missing, signaled as potential ventilation risk. The chemoreflex is overactive during hypocapnia, increased respiratory drive. The amygdala amplifies autonomic alarms. Sympathetic dominance. Prefrontal cortex struggles to dampen. Regulation fails. Sleep fragmentation worsens everything. Chronic hyperarousal. This chain creates a central integrated threat state where the brain operates from the assumption that the airways are compromised. It is a physiological consequence of lost nasal sensory input, not a psychological interpretation. 7. Summary of point 6 in greater detail. ENS leads to higher brain centers receiving poor, contradictory, or weakened information from the nose. The insula, ACC, and amygdala interpret this as a potential threat to ventilation. The prefrontal cortex's regulatory function is weakened, causing the entire autonomic system to slip into a chronic alarm state. This is a neurophysiologically driven process that affects breathing control, stress levels, and heart rhythm. Point 7. Deepened physiological review. Why ENS causes pronounced sleep disturbance and autonomic collapse. Sleep regulation depends on stable interaction between the respiratory system, the autonomic nervous system, the brainstem, and several deep brain structures. Empty nose syndrome, ENS, affects this system on multiple levels simultaneously. The result is sleep that is shallow, fragmented, and physiologically unstable. Below is a detailed explanation of how this happens. 1. Reduced vagal tone makes it difficult to initiate and maintain sleep. Intact nasal breathing, especially slow exhalation against normal nasal resistance, activates the baroreflex and stimulates the vagus nerve. Vagal activity is crucial for lowering heart rate, stabilizing sinus node rhythm, falling asleep, transition into deep sleep, maintaining normal heart rate variability, HRV. In ENS, much of the normal nasal resistance is absent. Exhalation becomes short. Baroreceptors activate less and vagal tone decreases. This leads to resting heart rate remaining too high, increased autonomic variability, delayed sleep onset, the body oscillating between sympathetic dominance and microarousals. This is a purely physiological problem, not psychological. 2. ARAR overactivation during sleep, respiratory instability. Normally, the lungs' rapidly adapting receptors, RARs, are dampened when air passes slowly through humid turbinates. In ENS, this damping is absent. RARs are triggered more easily at night by drier and colder air in posterior nasal areas, small fluctuations in airflow, faster gas exchange due to an overly open airway. RARs are directly connected to brainstem reflexes that increase respiratory drive. Result: faster breaths during sleep, increased switching between inhalation, and exhalation, more micro-awakenings, unstable oscillation between light sleep and wakefulness. This prevents sleep from entering stable. N3 deep sleep. 3. Nocturnal hypocapnia, awakenings and palpitations. When breathing is too fast, CO2 levels fall. During sleep, hypocapnia leads to cerebral vasoconstriction, fragmented sleep, increased sympathetic activity, pulse surges, unstable respiratory drive from the brainstem, chemoreflex sensitivity in the carotid bodies ENS patients often describe, sudden awakenings with intense air hunger, nocturnal tachycardia, dryness or burning sensation in nose and throat, markedly increased arousal after waking. This is well known in physiology. Hypocapnia is a strong wake-up signal. 4. Loss of normal sensory feedback from the nose. The brainstem switches up the arousal system. The brainstem uses continuous trigeminal sensory input from the nose as an indicator of safe, stable breathing. When this input stops, sensory mismatch occurs. Irregular signals reach the NTS, increased readiness in the brainstem arousal network. Activation of the locus coeruleus, noradrenaline. During sleep, this means the brain interprets breathing as potentially insufficient, becomes harder to switch off, is more easily woken, produces higher nocturnal sympathetic tone. This is the same mechanism seen with other vital sensory losses. The brain overcompensates. 5. Limbic structures amplify awakening reactions. In ENS, multiple higher brain centers are involved. Insula. The interpretation of "I can't feel my breathing" is amplified, even during light sleep stages. ACC monitors physiological mismatch and can signal threat during respiratory instability. Amygdala becomes more reactive when CO2 is low and vagal tone is reduced. Hippocampus is affected by repeated nocturnal hypocapnia and fragmented sleep, which amplifies stress responses over time. Together, this leads to higher probability of waking from small internal signals, increased pulse at each awakening, a strong alarm feeling at breathing-related micro-events, a self-reinforcing loop of hyperarousal forms. 6. Outcome: an autonomically unstable night rhythm. When all the above mechanisms combine, a characteristic sleep disorder arises. Difficulty falling asleep, easily aroused brain, high sympathetic tone throughout the night, low HRV, higher nocturnal heart rate than normal, recurrent air hunger after each awakening, lack of deep and REM sleep, pronounced morning fatigue. This leads to around-the-clock hyperarousal state, essentially identical to that seen with chronic respiratory alkalosis, but here driven by disturbed nasal signaling and failed autonomic regulation. 7. Short summary: ENS disrupts sleep by affecting vagal tone, reducing the body's ability to downregulate, RAR activation, creating respiratory instability, hypocapnia, triggering nocturnal awakenings, sensory loss, brainstem upregulation of arousal, limbic amplification, increasing autonomic hyperactivity. Together, this prevents the body from entering the low arousal state required for deep, restorative sleep. Point 7. Deepened physiological review. Why ENS causes pronounced sleep disturbance and autonomic collapse. Sleep regulation depends on stable interaction between the respiratory system, the autonomic nervous system, the brainstem, and several deep brain structures. Empty nose syndrome, ENS, affects this system on multiple levels simultaneously. The result is sleep that is shallow, fragmented, and physiologically unstable. Below is a detailed explanation of how this happens. 1. Reduced vagal tone makes it difficult to initiate and maintain sleep. Intact nasal breathing, especially slow exhalation against normal nasal resistance, activates the baroreflex and stimulates the vagus nerve. Vagal activity is crucial for lowering heart rate, stabilizing sinus node rhythm, falling asleep, transition into deep sleep, maintaining normal heart rate variability, HRV. In ENS, much of the normal nasal resistance is absent. Exhalation becomes short. Baroreceptors activate less and vagal tone decreases. This leads to resting heart rate remaining too high, increased autonomic variability, delayed sleep onset, the body oscillating between sympathetic dominance and microarousals. This is a purely physiological problem, not psychological. 2. ARAR overactivation during sleep, respiratory instability. Normally, the lungs' rapidly adapting receptors, RARs, are dampened when air passes slowly through humid turbinates. In ENS, this damping is absent. RARs are triggered more easily at night by drier and colder air in posterior nasal areas, small fluctuations in airflow, faster gas exchange due to an overly open airway. RARs are directly connected to brainstem reflexes that increase respiratory drive. Result: faster breaths during sleep, increased switching between inhalation, and exhalation, more micro-awakenings, unstable oscillation between light sleep and wakefulness. This prevents sleep from entering stable. N3 deep sleep 3. Nocturnal hypocapnia, awakenings and palpitations. When breathing is too fast, CO2 levels fall. During sleep, hypocapnia leads to cerebral vasoconstriction, fragmented sleep, increased sympathetic activity, pulse surges, unstable respiratory drive from the brainstem, chemoreflex sensitivity in the carotid bodies ENS patients often describe, sudden awakenings with intense air hunger, nocturnal tachycardia, dryness or burning sensation in nose and throat, markedly increased arousal after waking. This is well known in physiology. Hypocapnia is a strong wake-up signal. 4. Loss of normal sensory feedback from the nose. The brainstem switches up the arousal system. The brainstem uses continuous trigeminal sensory input from the nose as an indicator of safe, stable breathing. When this input stops, sensory mismatch occurs. Irregular signals reach the NTS, increased readiness in the brainstem arousal network. Activation of the locus coeruleus, noradrenaline. During sleep, this means the brain interprets breathing as potentially insufficient, becomes harder to switch off, is more easily woken, produces higher nocturnal sympathetic tone. This is the same mechanism seen with other vital sensory losses. The brain overcompensates. 5. Limbic structures amplify awakening reactions. In ENS, multiple higher brain centers are involved. Insula. The interpretation of "I can't feel my breathing" is amplified, even during light sleep stages. ACC monitors physiological mismatch and can signal threat during respiratory instability. Amygdala becomes more reactive when CO2 is low and vagal tone is reduced. Hippocampus is affected by repeated nocturnal hypocapnia and fragmented sleep, which amplifies stress responses over time. Together, this leads to higher probability of waking from small internal signals, increased pulse at each awakening, a strong alarm feeling at breathing-related micro-events, a self-reinforcing loop of hyperarousal forms. 6. Outcome: an autonomically unstable night rhythm. When all the above mechanisms combine, a characteristic sleep disorder arises. difficulty falling asleep, easily aroused brain, high sympathetic tone throughout the night, low HRV, higher nocturnal heart rate than normal, recurrent air hunger after each awakening, lack of deep and REM sleep, pronounced morning fatigue. This leads to a round-the-clock hyperarousal state, essentially identical to that seen with chronic respiratory alkalosis, but here driven by disturbed nasal signaling and failed autonomic regulation. 7. Short summary ENS disrupts sleep by affecting vagal tone, reducing the body's ability to downregulate, RAR activation, creating respiratory instability, hypocapnia, triggering nocturnal awakenings, sensory loss, brainstem upregulation of arousal, limbic amplification, increasing autonomic hyperactivity. Together, this prevents the body from entering the low arousal state required for deep, restorative sleep.